Have you ever had that deep, just frustrating ache in your shoulder that no amount of physical therapy seems to touch? That weakness that feels less like a simple pulled muscle and more like, well, like someone just cut the power. Today, we're going to play detective and investigate a hidden culprit that might be behind it all: the complex network of nerves that powers your every single move. So, what is really going on when the usual rotator cuff treatments just aren't cutting it? When that weakness feels so profound, almost like your arm is disconnected? We're going to look into a cause that honestly flies under the radar way too often. Okay, let's dive into this medical mystery. So, here's our game plan. First, we'll define what this unseen injury even is. Then, we're going to track two key nerves, the suprascapular and the axillary, and see exactly where they get into trouble. After that, we'll see how doctors can actually see the problem. And finally, we'll cover what treatment and recovery look like. First things first, let's get on the same page about what we're actually talking about here. I want you to think of the nerves in your shoulder as its electrical wiring. Now, when that wiring gets pinched or compressed, well, the signals just don't get through like they should, and that's exactly where the problems start. The official medical term is entrapment neuropathy, but don't let the fancy name fool you. It's really a mechanical problem. A nerve, which is supposed to have a nice, clear path, gets physically squeezed at a very specific spot. This compression can cause a whole range of issues, from a dull ache to serious muscle weakness, all because the muscle isn't getting the right commands from the brain anymore. Now, here's something that might surprise you. While we tend to think of nerve problems as an issue for older folks, this condition often targets the young and athletic. Seriously, picture a volleyball player's explosive spike or a baseball pitcher's throw. Those extreme, repetitive overhead movements can actually stretch and irritate the nerves, leaving them vulnerable. A previous injury, like a shoulder dislocation, can also set the stage for nerve entrapment down the road. Okay, time to meet our first person of interest, the suprascapular nerve. This guy is a major player in what's called the brachial plexus. That's basically a superhighway of nerves running from your neck down into your arm. And in the sports world, this particular nerve is the one that gets into trouble most often. And this nerve, it's a total workhorse. It provides the power to two of your key rotator cuff muscles: the supraspinatus, which helps you lift your arm out to the side, and the infraspinatus, which lets you rotate it outward. So you can see why, if this nerve is in trouble, these really basic, really crucial shoulder movements suddenly become weak and painful. So to understand how it gets trapped, we have to follow its path. It starts up near the neck, then travels across the top of your shoulder blade, and then it has to navigate two very, very tight spots. The first one is the suprascapular notch. Think of it as a bony little tunnel with a ligament for a roof. The second is the sphenoglenoid notch, another narrow passageway. These are the two main choke points where this nerve can get squeezed. And this is where it gets really interesting for doctors. Where the nerve gets pinched makes a huge difference. If the compression happens early in its journey, at that first choke point, the suprascapular notch, then both the supraspinatus and infraspinatus muscles are affected. That means you'll have weakness when lifting your arm and when rotating it out. But if the pinch happens later on at the spinoglenoid notch, it only affects the infraspinatus. That gives you just one specific weakness: rotating your arm outward. So the symptoms give doctors a massive clue about where the problem's located. So what's actually doing the squeezing? A lot of the time, it's something called a paralabral cyst. It's basically a little balloon of joint fluid that leaks out from a tear in the cartilage and presses right on the nerve. For athletes, it can be a traction injury, just from all that repetitive stretching. A big rotator cuff tear can also physically pull on the nerve. And sometimes, people are just built with a narrower notch, which makes them more likely to have problems. All right, let's bring in our second nerve of interest, the axillary nerve. This one faces a totally different kind of obstacle course, and it controls the deltoid, the main shoulder muscle you see in the mirror. The axillary nerve has to travel through a spot called the quadrilateral space. It's this small, four-sided window in the back of the shoulder, bordered by a bunch of different muscles and bone. And get this, the nerve has to share this tiny space with a major artery. As you can probably guess, it is a very tight squeeze, with not a lot of extra room. So an injury here can happen slowly over time, like with quadrilateral space syndrome, where stuff like fibrous bands or just bulky muscles gradually narrow that window. Or it can happen all at once. A shoulder dislocation is a classic cause. The nerve gets stretched tight over the head of the arm bone when it pops out of the socket. A fracture can also do direct damage to the nerve. Okay, so we've got our two main suspects, the suprascapular and axillary nerves.
We know they're potential crime scenes. Now, how do doctors actually gather the evidence to prove that a nerve is the real problem?
The star witness here, without a doubt, is the MRI. It's so powerful because it doesn't just show one piece of the puzzle, it shows the whole story. An MRI can actually see the cause of the problem, like that cyst pressing on the nerve, and it can show the effect of the problem, which are the telltale signs of damage in the muscles that the nerve is supposed to be controlling. It's actually pretty amazing. When a muscle loses its nerve supply, it changes in a very predictable way that shows up beautifully on an MRI. In the acute phase, right after the injury, the muscle gets all swollen with fluid, so it looks really bright on certain images. Then, as time goes on, fatty streaks start to show up. And finally, in the chronic phase, if that nerve doesn't recover, the muscle starts to waste away and get replaced by fat. This timeline lets doctors not only diagnose the problem, but also figure out how long it's been going on. Okay, so we've identified the nerve, the location, and the cause. We've seen the evidence on the MRI. Now for the final act, and the most important one, treatment and recovery. How do we fix this? Generally, there are two main paths forward. If there isn't some obvious mass, like a cyst pressing on the nerve, the first step is usually conservative management. That means physical therapy, changing up your activities, and just giving your body time to heal itself. And a lot of the time, symptoms get better within a year. But if there is something physically squeezing that nerve, or if the patient is a high-level athlete who can't risk permanent muscle loss, then surgery becomes a really good option to take the pressure off the nerve and fix whatever's causing the problem. Let's walk through a super common scenario, that paralabral cyst. First, the doctor diagnoses it on an MRI or ultrasound. Then they can perform what's called an aspiration. They literally use an ultrasound to guide a needle right into the cyst and drain the fluid out. This can give you immediate relief. The thing is, since that cyst is caused by a tear in the cartilage, it might just come back. If it does, the long-term solution is usually a minimally invasive surgery to repair the tear, which stops the leak at its source for good. And this quote from Dr. Aaron Alaya really sums it all up perfectly. These aren't your everyday run-of-the-mill injuries. They're pretty rare, but they are a very real, very significant problem, especially for young, active people who are constantly pushing their shoulders to the limit. Just knowing this is a possibility is half the battle in getting the right diagnosis. So the next time you hear about a shoulder injury that just won't get better with the standard treatments, it's worth asking, could this be more than just a muscle? Could it actually be a message, sent under pressure, from that intricate wiring that makes everything work? Thanks for joining me on this deep dive.